All right, good to see everyone. As you're tuning in, we're kind of going in live on certain channels. Are we out live on all now?
Almost.
Okay, so we're just waiting a second. So I'll wait a second and see. He's kind of, but good to see everyone. We're going to be having a conversation with Dr. Mark Bowling. I'll be kind of talking about that a little bit more in a second. But good to see everyone. It's just going to be, this is going to be a great information session, just to kind of alleviate fears and kind of let people know where we stand with things. Are we live now on all channels?
Yeah, we're live on it.
Okay, cool. So we're now live on all channels. Good to see everyone. Hi, my name is Father Ian Van Heusen. I'm sure everybody knows me who's probably following along with this. If you're not by some chance, you know, it's the Art of Living Well. I'm also at ECU Newman in St. Peter's. So what we're going to be doing today is we're going to be having a conversation with Dr. Mark Bowling. I'll have him introduce himself in a second, give kind of his credentials, his background, and then we're going to jump into the COVID-19 crisis. Where are we at with the information? He's going to give us good information. Then we're going to discuss some of the safety protocols to keep folks healthy while they're here at ECU Newman and how we're going to proceed with the college students in the coming weeks. But before we get into that, let's start off with a prayer. Father, Son, and the Holy Spirit. Oh, Heavenly Father, we just ask you to illuminate our hearts. Help us to recognize the truth about ourselves and about the world, but particularly about this situation. That we may not give in to fear, but rather that we, through information and through education, may come to recognize what steps must be taken to keep folks healthy, but also to live our lives as we are called to do, to participate in your mission. Help us to always keep in mind that while it's good to keep folks healthy and to try to do our best to be precautious, that we should not be afraid, but rather always should carry out your will with complete abandonment. We ask all this through Christ our Lord. Amen. Father, Son, and Holy Spirit. All right, so Dr. Mark Bowling, please tell us a little bit about yourself, kind of fill us in.
Well, first of all, thank you very much for being here, and I just want to compliment you, first of all, on that prayer, because where I came from, that's called a soul stirrer. You got us going, so I really appreciate that. My name is Mark Bowling, and I'm one of the physicians at ECU School of Medicine, and my particular interest in my specialty is in pulmonary medicine and also in critical care medicine. And because of this crisis, it's really brought out our abilities as pulmonary critical care docs. We've been called on to take care of a lot of these folks that are sick. So I've been extremely fortunate, very thankful to you, Father Ian, to giving us this opportunity that maybe we can answer some questions. I'm extremely excited that I understand there's 29,000 students now at ECU hitting the campus today in the next few days. Well, welcome, guys. I'm glad you're here. I'm a pirate too. So let's get it on and figure out what we got to talk about today.
Well, thanks. Go ahead.
All right. So first of all, first thing you're going to say is you're going to tell me about wearing a mask. I am going to tell you about wearing a mask because that's what we need to do right now, and I'm going to give a little information. Why? But I'm not wearing a mask, and Father Ian's not wearing a mask. I know people are out there saying, why aren't these guys wearing masks? Don't you think so? I know that's what they're saying right now. That's what I'd be saying right now. So you should be wearing a mask if you're inside, but notice we're a little bit further apart from each other. Now I'm speaking a little bit forcefully, I'm a little bit animated, so I probably want to get a little bit further back. But that's why we're doing it today, because we want to make sure we get this information out to you guys, and I want you guys to understand you should be wearing a mask when you're in a group of people. You really should, and the chancellor has told us you got to wear a mask when you're here on campus, okay? And I'm going to give you a reason why you should be doing that and what that means. All right, so put together a little presentation for you. You're going to go through some basic information, and hopefully this is going to be able to help you a little bit and going to give you some numbers, particularly related around you guys, the guys of the age right now at ECU, how this might affect you. Could I get the next slide, please? Okay, so first of all, a little bit of terminology. Now, I am a physician. I'm going to try not to get too nerdy on you, a little bit of doctorish. Going to give you more numbers and more practical things, but first, what is SARS-CoV-2? Well, that's the name of the virus. And then we talk about the coronavirus disease in 2019. COVID-19, when you hear that, we're really talking about disease. And the disease is a manifestation that virus caused. And of course, a pandemic means that there is disease that is all over the place, and it's pretty much gone worldwide. I'm sure you guys are sick of hearing about this. We're all sick of hearing about this, but you know what? It's going to be here to stay for a while, and we're going to need to deal with it, and we're going to start, and we're going to tell you how to do that right now. All right, next slide, please. Okay, how is it transmitted? I know you've heard this 1,000 times, but it's really transmitted by respiratory droplets. And we're going to talk about what a droplet is in just a minute. Also, it can be transmitted by contact. If I cough on my hand and I've got a bunch of RNA particles of the virus sitting there, and then I go and I touch something, it's going to be on that object for a while. If you go by and you touch that object and then you touch your eyes or you touch your mouth or something else, then it's possible you could get the disease. And we'll talk about what that means and how much of those RNA particles, that virus, you need to get sick. But in general, that's how it travels. It can travel by what's called airborne, and airborne precautions and airborne transmission, basically means that those particles, those RNA particles, the virus itself, are actually smaller. And when they become smaller, they can drift and they can go for a ways. And that's the airborne part of that. And there are certain things that we do in the hospital, certain procedures that are done that cause these particles to become smaller and to be projected further. And that's what we mean by airborne. By far, the majority of the disease is transmitted by droplets. And droplets are bigger pieces of the virus, of RNA, that go a distance but not as far. They kind of come out and they drop. Next slide, please. All right, this is kind of going over what I just mentioned, is the difference between what we call airborne and what we call droplet. Airborne, as you can see, they're bigger particles, and you can kind of think about 5 microns as being about the size of a hair follicle. Those are full of RNA, and that's what the virus is. It's a certain type of RNA. And you can see those come out and then they kind of drop, whereas the airborne particles are much smaller and they can drift a little bit further. So if I'm standing, say, 6 feet away from Father Ian, and I cough real loud, or I start singing, or I start yelling at him, or something like that, then those viruses are going to come out, but they're going to drop just about within 6 feet. Whereas if I do a certain procedure, say like if I have asthma, and I do a nebulized a treatment, and the particles are much smaller, and they actually go up into the atmosphere and become almost vaporized, then that can go a little bit further, and it might go further than 6 feet, but that's in particular situations. Next slide, please.
So, Doctor, I have a quick question for you. As we were first talking about, you were talking about the droplets. So really the concern is not just speaking or just pushing air out, but if there's droplets attached to it, basically, right?
Yeah, so
like at this point right now, even though we're in the same room, there's not a lot of us in here, there's 3 of us, it's a bigger space. Droplets aren't going to travel as far, so we're fine not wearing a mask, right?
theoretically they wouldn't. And yes, in this situation, it is probably more likely that you're okay not wearing a mask than if you are wearing a mask. What I would advocate, if you have any concerns, wear a mask. Certainly, as you mentioned, if you're closer together or you're in a smaller area, absolutely. But to your point, you and I are about this far distance away. I don't know if you could tell that out there, but we're about 2 arms lengths away. That's approximately 6 feet. And you're exactly right. If I'm just sitting here talking, not in my animated, crazy tone, but just normal, some of the particles are going to come out and going to fall. And it's not exactly how much, but how much comes out and how long you're exposed to it.
Yeah.
If we're sitting here and we're talking for hours, you're probably going to get a pretty good load of that,
Yeah.
if I'm infected.
Gotcha.
If I'm infected. Which goes to the big point. If you have symptoms and you're sick, stay at home. That's what's important about this.
Yeah.
And I know not everybody has symptoms, but by far the majority do.
Absolutely. Thanks. Let's get back into the slides.
All right, but this is just a little slide to kind of show you the different kind of transmissions again. So you have the infected person over there. It's got all the black dots around them. And then notice that the droplets, that those are actually bigger. Then it goes into the droplet nuclei. Get a little bit nerdy. Any science people out there, you know what I'm talking about. And then you can see those travel a little bit further to the susceptible person, whereas the contact, you see, goes from the hands or for some other process, and then it goes to the infected person. So again, to your point, Father Ian, is that when we're sitting here talking, or if I start singing or yelling, then more stuff's going to come out forcibly. But if I'm just sitting here talking to you in a normal tone, some's going to come out, but it's going to come out and drop. However, you don't necessarily need to take any risk. Again, if you don't feel comfortable and you're in a position and you're in a room talking to someone that maybe you don't know, or you know, it's fine to wear a mask. Wear a mask if you feel like you need to. I would advocate always wearing a mask in a very public situation, just like the Chancellor has mentioned that we need to do when we're on the ECU campus. Next slide. Okay, this is about outdoors versus indoors infection, and this was actually a study that was done. And the whole point to this slide, not to confuse everyone, is that when you're outside, if you think about it, there's much more space. The particles can actually disperse a little bit easier, and they get kind of diluted. So you're less likely to be able to transmit the infection as easily as you are inside. And that's exactly what this slide is showing, is that most of the secondary infections took place indoors, despite only 20% of the contacts being indoors. So again, being outside is good. It doesn't mean that you should not wear your mask. I think if we were outside right now, Father, and I wouldn't have any problem with us wearing a mask. Just you and I, we're this far away. That's no problem.
You mean not wearing a mask?
Not wearing a mask, yeah. But if we had, 50 people all standing right here, probably still be okay, but we probably should be wearing a mask.
Just to take
close together.
So like, for example, for our opening mass and for our welcome week celebrations, we're going to be having bigger groups. So we'll be wearing masks just as a precaution.
Yes.
But it's not as strictly. And by the way, I do want to say one thing as we're continuing, because I should have said this at the beginning, and if we could put this in the comments section, Tim. If you have questions or comments, please comment. We'll probably be going into it in probably like 10 or 15 minutes at the close of the presentation and just kind of doing some feedback. But this is a good start so far. You can continue to talk on this. I'll pass the mic back over to you.
All right. Next slide, please. I don't know if I'm going to get invited back after this, but
oh, you're doing great. No, you're doing
right.
great, Todd.
So symptoms of COVID, and of all the parts on this slide, I tell you, I love the top corner the most. Facts, not fear. And that's really what this is about today, is to really get to you and tell you the facts. There's been a lot out there, a lot of information out there, so we're going to try to bring you exactly what the facts are so you can make your decisions on facts and reason and not let fear drive your behavior. Be appropriate, but be factual. Here's the symptoms of COVID-19. And the problem with COVID-19, as you can imagine, is that it looks like a common cold. I mean, we all get colds, we kind of walk around, try to stay away from people. Now you got to be a lot more cognizant of it. Understand there are other disease states still in existence besides COVID. And you probably will get a cold that is not COVID sometime this year. God forbid, you probably will. You've got to pay attention to your symptoms, and you still got to consider, could it be COVID? But more likely, you might get something else. Here are some of the symptoms, though. Fever, cough and sore throat, difficulty breathing, chills, muscle aches and pains. I have seen a lot of patients with COVID, and there's been a lot of variation in symptoms. The things that seem to be common to me amongst almost all of them are the following. Everybody talks about how bad of muscle aches and pains they have. Now, this isn't like, oh, I'm just a little bit sore. This is like somebody took you out back and really got a hold of you. This is like I just got through running a marathon. I mean, you are sore everywhere. I mean, your hair hurts. My hair don't hurt, but your hair might hurt. Also, you tend to lose a sense of smell. I don't know what that is, but that's very, very common, and almost everyone I've talked to that's had COVID talks about they lost a sense of smell and taste. Your respiratory system is mostly in the upper airways. It can develop in the lower airways. We tend to see the people who have the pneumonias more in the hospital, but most of the people that I've talked to outside of the hospital talk about mostly kind of head cold symptoms, loss of smell, and bad muscle aches. But any of these symptoms could be there. And here's the point I want you to hear. If you feel sick, you should stay home and or seek medical attention. That's the most important thing you can do to keep from spreading this. Again, if you get sick, you should stay home and seek medical attention. It does not mean that you have COVID, though, but you have to consider and have a higher level of suspicion in this day and time. Next slide. This is just kind of showing, this is a little nerdy slide, kind of showing you basically the disease course. Notice that the incubation period can be about 5.1 days was kind of the average time. So you can kind of cook around for a while. And that's one of the scary things about it. And I think what happens is you get exposed and you probably get infected. About a day or two, you feel normal. Maybe around day 3, you start having signs or symptoms of a cold. Around 4 or 5, you really start feeling stuff either like a head cold, muscle aches and pains. When you start getting around 5 or 6, 7, I think that's when you get the symptoms of the pneumonia, maybe the loss of smell, the loss of taste. And it can get real serious. And as you notice, when people get really sick into what we call that ARDS, which stands for Acute Respiratory Distress Syndrome, that's where your body just kind of goes nuts. And what's happening is your body's trying to fight off the infection and just goes haywire. And then you wind up damaging a lot of things, and then you recover. And in a minute, the good news is I'm going to tell you that majority of folks, by far the majority, I want you to hear me, the majority get better. The majority, by far the majority, live through COVID. And kids your age, particularly around the college level, there's even better news. Very, 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 very few, thank God, of those individuals have actually died from this disease and have full recoveries. Next slide. Okay, let's get into some of the numbers. I'm going to try to back up what I was just talking about. This is actually from the Center for Disease Control website. This is not my data. This is right from the source. And where it says total cases, as of July the 31st, that's when I got that information, there was about 4 million cases in the United States and 151,000 deaths. That is horrible and it's tragic. But let's put that in a little bit understanding. Okay, that is 3% of those 4 million cases, 3% of the folks unfortunately passed away. That's still a pretty small number. Tragic, but a small number. Now let's look at the total number of people in the United States. There's about 328 million from 2019 census of citizens in the United States. So how many folks are infected? It's 0.0013, so 1.3% of the U.S. population as of July the 31st has been positive with COVID. If you look at the death rates for that, out of the U.S. population, that's 0.04% have died from the U.S. population. I don't want one person to die, but when you look at those numbers, it's still, thank God, small. It's not overwhelming. We don't want it to get that way, but I want you to understand the facts about that. Next slide. So this is again from the CDC website. I use the arrows here to kind of point out the folks in your age group. I want you to hear me very clearly. I think COVID is very serious, but we've got to put it into what the reality and the facts are. And the facts for folks who are 15 to 24 out of the entire United States, now that was out of all those cases that I showed you, 4 million, from 15 to 24 years as of July the 31st, thank God only 202 people have died. Now, who dies from COVID? Unfortunately, the people who mostly die from COVID have been folks who have underlying medical problems. And I'm not downplaying that at all, but most of these folks, even the young ones, unfortunately have had problems where their immune system isn't working correctly. They've had transplants, they have congenital heart disease, they have some other kind of problem that has really predisposed them to really get hit hard by this infection. That's why, if you look at this chart, as you get older, us older folks, and I'm in that category, we tend to be less healthy and do have some comorbidities, and then we tend to have more problems with this. It's a horrible disease, but it's a fact. If you have comorbidities, you certainly are more susceptible to have very serious complications from COVID. Fortunately, in guys that are your age group, it's not that common to have those comorbidities, and you can see the numbers by far have done very well, thank God, through this crisis so far. Next slide. This is just kind of backing this up a little bit. Took two kind of hot spots, New York and California. You can see the 18 to 44-year-olds was about 4%. Majority of those were actually less than 30, were over 35, excuse me. And then in the California, you can see from 18 to 34 was 1%. Just a little fun fact about this, I don't know if it's a fun fact, but there are two types of the virus, two strains. There's a Wuhan strain. That strain tended to come in on the West Coast. And then there's the Italian strain, which tended to come in through New York and the East Coast. And right now, at least from the data that we have, it looks like the Italian strain has been the ones that's been pretty difficult to manage and can hit you pretty hard. But again, looking at overall United States, 15 to 24-year-olds, it's still pretty low, 0.1% chance of death so far, particularly for people in the age group that's in college age. Next slide. Again, just showing you, this is looking at pneumonias, flu, COVID, and then it's looking at age groups. And at the very, 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 very bottom there, it's almost on the flat line. You can look at folks that's between about 18 and 35, 40. You can see that, thank goodness, so far, the overall death rate has been very, very low. Next. This is North Carolina data, very important. We're in North Carolina. Again, the numbers, thank goodness, are smaller. There are 122,000 confirmed cases. I just saw before I came over here that the deaths in North Carolina, unfortunately, right now are around 2,000. If you look at that, that's about little over 1%. I think I calculated 1.7%, something like that. And you can see the number of hospitalized patients as well. Next slide. This is just showing you, again, all deaths, and this was as of, this number is about 3 or 4 days old, so it's, again, over 2,000 now. But you can still see that the case fatality rate is still fairly low, and it's 5% for the ages 25 to 49. Next slide. And this is a nice pie chart that I actually got from one of the websites. I think it's from WITN, and I thought this was great. They use CDC data, and what you'll see here where it said percent cases, the one where I have 18 to 24, that's obviously the age group that we're talking about. And notice on the other pie chart where it said percent deaths, there's not, that color's not there. So there's been 0 deaths so far between 18 and 24. And then where I've got that 1,903 deaths in North Carolina, what I'm saying is it was 5% from, what was that, 18 to 44, so that was 95 people, at least at that time in North Carolina, that had passed away from that age group. Next slide. So again, this is just kind of showing you what are the comorbidities that we talked about. This is North Carolina data. So cardiovascular disease, diabetes, chronic lung disease, kidney disease, and then other diseases, which would be things like connective tissue diseases where you might be on some medicine that'll lower your immune system, human efficiency virus, anything like that would go in the other category. Next slide. And this is looking at folks, again, by age group that had at least one comorbidity that had confirmed COVID-19 cases. And you can see the 18 to 24, that about 6% of them did. Most of them did not. And 58% we had missing data, but most likely, based on the death rate, we assumed that that was extremely low. Next. And this is looking at the actual confirmed death cases. And if you look at 18 to 24, 50% of the folks did have comorbidities, 50% was unknown. Next. So what does all this mean? It means the relative risk of death in the age group that we've talked about is about 0.005%, so 5 out of 1,000 who have tested positive. And this is out of the entire 4 million cases that we talked about. If you're healthy, your relative risk to test positive is closer to 5 out of 1,000. And for every 28 to 30 out of 100,000 people from the ages of 15 to 24 die from unintentional injury, car accidents, falls, and drownings before you will, obviously, COVID. And then age 15 to 24 years, you have a high risk of dying from suicide, unfortunately. So it's 8 to 10 out of 100,000 than you have from dying from COVID. Next slide. So this is the way to put all that together. I really like this slide a lot. And this, again, is data that's been calculated from the CDC, but it's got it broken down by age group and what people are most likely to die from. And it's in order. So from the 15 to 24-year-old age, most people will die from some kind of accident, unfortunately. You can see suicides, homicides, cancers, heart disease, and congenital anomalies before you see COVID-19 come in there. And then as you get older, you can see that COVID-19 starts creeping up. The point of this slide is to tell you that, yes, you've got to be very serious, and yes, you've got to take COVID-19 seriously. And yes, you've got to be very in tune that when you're sick to stay away from people and be responsible. And yes, when you're out in public, you've got to be responsible and think about wearing a mask and social distancing and washing your hands. But I think what I'm hoping driving home is do not let fear stop you from living. You can still live your life. You can still do the things you need to do. Just be smart about it. Follow the rules and be cognizant of other people. And if you do get COVID, God forbid if you do get COVID, you've got a more than excellent chance of not having any very significant problems with COVID, most certainly not death, based on the statistics, if you're healthy. But we still have to be very cognizant and take it for real. Next slide. This is just showing you the older people. I don't know if there's any older people out there like me, but I'd probably want to see this too. But notice still, you still have a higher chance of dying from heart disease and cancers than you do from COVID at this time. Next slide. So what can you do to lower your risk? You guys know this. It's what I've been harping on. Father Ian and I, we called each other out. We're not wearing masks, and I know that I'd probably be saying that if I was watching this too, but wear the mask when you're supposed to wear your mask. Listen to what your doctors have to say in your local health departments. Wear a mask, think about distancing, and then wash your hands. Pretty simple stuff. It's the same stuff that our moms told us. Next slide. Again, this is why you might need to wear a mask. If I wear a mask and you wear a mask, and if I'm infected, you can see that it does help to decrease the amount of droplets that could get to you if I'm infected, if you wear a mask and I wear a mask, as opposed to if we don't. And you can see that right there. Next slide. So bottom line, respect COVID, but do not fear it. Respect COVID, but do not fear it. It's real, it's here to stay, and we're going to learn to deal with it. You're learning to deal with it. You're here now, you're here at school, you're ready to go. Respect it, don't fear it. Don't be afraid. Live your life. Just be smart, use common sense, and don't be reckless. Reason over fear. Remember the 3 W's. Wear a mask when you're supposed to. Wash your hands. Wait. And then also facts, not fear. It's a very, very low likelihood of people that are in your age group that are healthy to die from COVID. Again, I'm not telling you to go out and start going to all the frat parties and not wearing your mask and doing all this stuff. What I'm saying is be very smart about it. Wear your mask. And if you get sick, isolate yourself, seek medical help. And I promise you, you're going to be fine. I hope this is helpful to you.
Thanks, Mark. So we got a lot of questions, a lot of chatter.
Nobody's talking about my bald head, are they?
No.
Okay, all right.
A few people asked for your number. No, I'm just kidding. He's married, ladies. So I'm curious. So somebody said, somebody asked, Father Ian, do you wear a mask at all? Why or why not? So they asked me personally. And let me see if I understand this right and see. So generally speaking, now I try to respect people when I'm in public, walking in and out of buildings. You're walking around randomly with people. But really the concern is droplets versus airborne, right? That's a distinction you made. I want to come back to that. Let's see if I get this right. So with the airborne would be like right now somebody would say, well, I'm speaking and I'm pushing air out. And if a virus is more airborne, then that would be more of a risk. But if it's droplet, as long as I'm not doing aspirated stops in a dramatic way, like where you're, because there's certain kinds of ways you speak where you push a little bit of saliva out.
Yeah.
So that would be, I am one of my big concerns, and I've talked about this a lot, and hopefully I'm not putting you on the spot. We can
Sure, no, that's all right.
We can always cut it
That's
out
what
a
I'm here
little bit.
for.
So is one of my big concerns as a pastor is the mental health and the fear factor,
Yes.
particularly among college students.
Yes.
Because I have yet to, I'm trying to think how I should say this without breaking confidentiality. I've yet to deal with a young person dying of COVID-19, but I've dealt with many mental health situations and mental health deaths related to COVID-19.
Yes.
And so I think one of the things is what we're kind of advocating, what ECU is advocating, is take precautions to help slow the spread, but not to be afraid, because really you're not really at risk of dying, kind of thing. I mean, there's always a risk, but what we're saying is the risks are relative. Like there's more, the unintentional injuries you're more likely to die of way more than COVID-19. So like it's a hard thing to understand sometimes, to wrap your mind around.
Yes.
Like we're taking this precaution with this particular disease. It might be debatable whether we should do this with every disease, and that would be a longer conversation. But you would say, if you're not, see the policy I've taken, I'm not sure if there's a question in this, and this is kind of speaking to that question. The policy I've taken, tell me if I'm completely wrong, is I'm more precautious when I'm around at-risk population, is the long and short of it, if that makes sense.
Yeah, you hit on a couple of things that I think are important, and I'll try to go through those one at a time. You mentioned airborne versus droplet. and I probably opened a little bit of can of worms for that, but airborne basically means that the RNA particles have got to a point to where they're almost, I don't want to say evaporated, but they're smaller, and they can float and go further. Now what that means, this mask ain't gonna help.
Yeah, and that's what a lot of people say masks are useless.
For airborne. Now, what makes it airborne? That's the question. And we've debated about this in medicine for a long time. So I know that if I go and I do, what I really do a lot of is something called a bronchoscopy. And a bronchoscopy is where I really snonker someone out, and I take a camera with a light on it, and I go down into their airway, and I look around, and I biopsy, and I remove tumors, and do all kinds of stuff. But when I do that, the process of doing it causes vaporization. And those particles can come out smaller. Or if I have to put a tube in someone's throat, that causes that stuff to come out more.
Yeah.
When that happens, we don't wear these. We wear what's called N95 masks. You probably see the CDC with those hoods on and all this stuff. You know, probably seen Hot Zone, you get to walk around, look kind of cool with it. Well, that's when you wear that stuff and when you have those masks on. That ain't gonna happen. From you and me sitting here talking, it's not gonna be airborne most likely. Very unlikely, unless I sit here, and the reason why I use that nebulizer thing, and that's probably the closest thing I could think about, where someone at home might have asthma, which needs to be careful, by the way, about COVID. But using a nebulizer, that would aerosolize things.
Yeah,
I hope that's making sense.
That makes perfect sense.
You and me sitting here talking, most of the time it's going to be the drop.
Well, you're helping me sort through a lot of misinformation on the internet because I see a lot of stuff on social media, and I'm not always sure what to make heads or tails of. So really,
the only thing I want to, before I forget, Father Ian, it's very, very, very important, because you said something and I meant to say this, and what I really want to tell the people out there, guys, again, it's very serious about COVID. I want you to live your life. I don't want you to be scared. But what I do want you to do is think about your neighbor. And what I mean by that is that most likely, so far, thank God, you're going to be fine as far as a threat of death with this. But you not meaning to, you could transmit it to the person down the street at the grocery store who's the 60-year-old person who's on dialysis. And that person's not going to do well. So that's why wearing that mask, staying home, doing those social distancing, staying home when you're sick, doing social distancing, wash your hands, that's what I'm really pleading and begging for, is to think about those things, because it's the transmission to the people that you mentioned, Father, and exactly the vulnerable people. That's the folks who are dying from this, and I see them every day. I watch the docs that I work with every day and the nurses battling to try to help these folks. And by far, I'm telling you, just from my experience, almost all of them have underlying medical problems, dialysis, heart disease, lung disease, something in their older folks. That's what I want you to really get through your head and I want you to hear, okay? Think about your neighbor. Think about if you're spreading it to other people, particularly vulnerable people.
Yeah. So I have a question. Actually, this one's probably more for the university, but I think we might know a little bit about it. With a son going into the classroom at ECU, should he wear a mask? First of all, ECU is requiring masks when you're on campus all the time.
That's my understanding, correct.
Yeah, so that's, I think what we could say is there could be a little bit of nuance in other situations, but ECU's asking us to do it, let's do it. But if you're in, there could be a little bit of nuance if you're in a space, if it's just, it's one of those things where I think you've done a good job of presenting how that could play out.
Yeah, if you're walking by yourself to campus, to class, and there ain't nobody around you, you might could have your mask down here or take a break. And I'm telling you guys, I wear this thing 12 hours a day. I get it. It gives you a sore. I get it. It's okay to take a break every once in a while. If you need to pull it down for a second, take a couple of breaks, you ain't around anybody, okay. If you're walking by yourself outside and ain't nobody around, I don't say you necessarily need to wear a mask, but you need to be cognizant that if I'm sitting here and I'm walking up and I see Father Ian, then maybe I should put my mask on. Just use your common sense about how you'd want if somebody was approaching you if you thought that they might be infected, that's all. And I hope that's answering that question.
And it's funny, yeah. And I think ECU is going to have those policies, and we'll just respect that. But they said the parent says, but it's still a bit concerned as a parent, we want to be diligent. And what I would say is like what we kept saying over and over again, really, unless there's comorbidity, I'm just throwing that phrase out there. I mean, I kind of know what that means.
Yeah.
I did not know what that word meant 6 months ago. But what you're saying is really, unless you're in an at-risk, I'll put it that way, you're in an at-risk group, there's very little concern. It's more slowing the spread to vulnerable populations.
Yeah, and again, I don't want to downplay, I don't want anyone to get sick. And I will tell you right now, I would be shocked if there's not some outbreaks this year. There's going to be 29,000 people. It's our job to try to limit that the best we can. Look, based on the data that I've showed you, statistically, and I know how statistics are, the chances of someone in this age group dying from it is exceedingly low. But that doesn't mean we don't need to take it serious. We just have to put that in a perspective and say, okay, I'm going to live my life, I'm going to follow the rules and do the best I can. If I get sick, I'm going to seek medical attention or stay at home, try to make sure I don't spread this thing, and then just go forward. Yeah. And I do believe you need to be diligent. I totally agree with that. Yeah. But don't let it stop you from functioning.
Absolutely. I'm going to switch this one up a little bit. So I'm going to read the question, but I think I want to rephrase it because I think I know your answer on this.
Okay.
I'd be curious. So is there a concern for ECU students coming back and public schools going back to personal instruction specifically for Pitt County? You have kids in schools.
Yeah.
You know, do you want your kids back in school?
Yes.
Yeah. Why would, as a doctor on the front line, why would you want your kid in a school right now? If that's not too hard of a question.
No, and I'm going to try to, I'm going to answer this the best I can as a father, obviously. And then I'll try to answer it as a physician, but that's hard, right? Because I am a dad, no matter what you say. So based on my information, my experience, I've seen it, I've been there, I've studied it. From my information, my experience, I am not concerned for my kids' safety as far as a threat to their life for COVID. My kids are 10, of going to school. I am a little bit more concerned with their mental health, with their development, as you mentioned. Yeah. I do have some concerns, and this might not be as founded, I'm just being honest here, about their ability to learn that interaction as opposed to home and the computer and interaction, and not to say that it's not helpful, but yes, I want my kids to go to school because I think that it's healthier for them. I think their chance for their risk to their health is low. Now, what is the risk? The risk is that they get sick and they're going to be okay, they're going to be sick, but they might bring it to my wife or to their granddad, or God forbid to the teachers, or to the person that works in the school that has diabetes and hypertension and is 65 or something of that nature. Yeah, I do see that and I worry about it. So what I pray and I hope is that the school, just like ECU, has put some things in place to try to help prevent that. And then for us that are working in that field, I mean, I'm in the line every day. We have to understand those risks and then make sure we keep those precautions and do the best we can. So that would be my answer to it.
That makes perfect sense. Okay. So there's one that's kind of technical. I have no idea what this means. And I know this woman, I know her actually from Fayetteville. So kind of a technical question. What about antigen testing?
Yeah.
And then she clarified a little. I'm reading that antigen testing is super fast, minutes instead of days, but less accurate than PCR. Maybe a tool universities can use?
Yeah, so antigen testing is very good. So must be a scientist out
yeah,
there.
there definitely is.
So,
she's definitely commented on stuff. And,
yeah, so antigen testing itself, now we're doing PCR now, and you're right, there is a problem with PCR. It's good and it's bad. And what I mean by that is say, for example, I got COVID right now. I'm going to test positive from a nasal swab. I do my 10, 14 days. I'm feeling good now, and I'm outside running. Feel good. You swab me, I'm going to have COVID. Why? Because I might have dead virus in my nose. Can I still spread it? I don't know. So actually, could antigen testing pick up more accurate, more quickly? Maybe. We're not using it in the hospital at all. We are going to antibodies, so we're looking to see if you're making antibodies. And again, you're only good as your test is, right? And there's a lot of tests out there right now. So we have an algorithm that we follow, and I hope this is going to answer their question, where we do so many of the swabs based on time that you've had the disease and your symptoms, and then we'll check antibody tests so far after to see if you've made antibodies, and that helps us to understand, and I think what they're getting around is not only how do you diagnose it, but how do you know you're no longer infective? How can I not give it to you? So with that combination is what we've kind of gone to through the hospital to say you're COVID clear. Because we have patients who are recovering and we keep them in isolation for weeks. And at some point, they're no longer infectious. So antibody tests are going to be real big, I think. How good the tests are, I'm still kind of up in the air about. We're doing broad testing sometimes at the hospital, even among the people who work there, just to see if people's been exposed and they don't know it, making antibodies. I hope that answers your question.
Yeah.
That's going to be a big, huge, I mean, you can see industry's going crazy over this stuff right now. Everybody wants to make a test or a drug.
Gotcha. Which I think one of the questions we've talked about a little bit. One of the things that I think people have a challenge with, and we've talked about this, and forgive me if I'm putting you on the spot again, is the science behind this is not as precise, right? Like there is, we have to admit that, like even right now, I was debating if we should bring this up, but I think it would be a good thing to bring up to employ empathy, is that there's probably disagreements among professionals, and just because somebody disagrees with you or disagrees with the ECU policy, now we're going to follow the policy, but that doesn't mean they're stupid, that doesn't mean they're some kind of backwards person. Like there's intelligent people who have varying views on this. Could you speak to that a little bit?
Yeah, so this has been really interesting process for multiple reasons. And in medicine, we're scientists, so we do studies and we look at things and we try to gather data and then we see if something works or not based on those scientific principles. Sometimes that takes time, particularly in medicine it takes time. We haven't had a whole lot of time, right? People were dying, they're still dying, and we didn't know what to expect. So studies and things were coming out much quicker than they usually do. And everybody's doing their best. Everybody's coming from a good place. They're trying their best in their heart. But things that we knew 3 months ago that we thought was the golden ticket, now looks like it's probably not. Yeah. And to be quite honest with you, my gut feeling is a personal thing. I don't think we're really going to know for another year or two what really is what. Because to really determine how you're going to treat something, sometimes it takes a couple of years to see the long-term effects and what happens. Gotcha. So what's happened has been a little bit kind of cool, and I don't mean that because people are getting hurt, but docs have been docs. They've gone out and they've done the best they could. They've looked at the pathophysiology, they've looked at the patients, they've looked at the pharmacology. They said, you know what, this might work. The downside is pretty low to give this drug. It might help. We got to try it. And they've done it. And that's a lot of what medicine has been through the ages. And that's kind of where we're at right now. And I've been, not because I was involved, I stand in awe of all the medical professionals out there. And I'm not just talking about the docs. I tell you, my true heroes have been the nurses and the care partners and the lift teams and the people at the hospital. Here I am as a doc sitting outside that room, and I go in maybe once a day and then I kind of come out and I'm sitting there and I walk and I can see through the windows. Those nurses are in and out and in and out and in and out of those rooms multiple times a day, never blink an eye. Those lift teams that go and have to move those patients in and out and in and out and in and out, the amount of exposure they have to relieve the suffering of those patients is just incredible to me. Those are the people I just really take my hats off at awe at every day.
That makes sense. What was I going to say? Great stuff, by the way. I think we might have to do this again. We're getting a lot of great responses. Well, it might be good to consider doing this as a way to update our community, because I know I've really benefited from our conversations and the doctors, because one of the things I was fortunate very early on was the majority of my information was not from media. I hate to say media. I mean, I know there's some people in media who are honest journalists, but we know right now there's a lot of hype on both sides. There's just a lot of misinformation. So having a doctor just, is willing to kind of flesh things out. One question, I want to comment a little bit on this first, but I'll let you comment too. What high school sports would you consider? Oh, actually, no, I'll have you talk about this first. I think I misunderstood it first. What high school sports would you consider the safest for student athletes to play?
Man.
Yeah. I mean, I think the big thing is, I will say something. We're not worried statistically about high schoolers dying, right? Like, can we say that definitively? Like, I mean, is that too bold to say?
I think it's objectively looking at the data that we have so far in this area right now that we've seen, I would think that's an accurate statement. Yes.
Yeah. So the big concern is not for the student athletes themselves. It's for grandma, grandpa, or the other people in their circle that might have high risk.
Unless, again, just to reiterate this, unless even that young person, God forbid, has a comorbidity.
Yeah.
Because some young people do, right? I mean, so you have to be very, very cognizant of that. But in general, most kids don't, right? I mean, most kids are usually pretty healthy. So chances are yes. So it's not the athletes, not that we don't care about the athletes. I don't want people to think that. It's that we're talking about a risk of very, very serious injury or dying is pretty low in that sense from COVID.
Yeah, and so hypothetically, if you're planning your family strategy for the next 6 months, and you have a grandparent who's at higher risk,
yes,
is you could hypothetically still visit them, but just take some precautions, right?
Yeah, absolutely.
So like
yes.
social distancing,
yes,
like things like that. Yeah.
And again, you got to be kind of smart about that. I mean, if I was, let's say I'm a high school student, and I hear this and I've taken it to heart, and I found out that a kid in my class that I sit right next to is COVID positive, but I feel fine. Okay, I feel fine. Well, I might stay home for a few days and not visit grandma or granddaughter, and give myself 3 or 4, maybe 5 days to make sure I'm not
It's
getting
not the end of the
symptoms
world.
or sick.
But don't cut yourself off for 6 months.
Yeah. If I think that's reasonable to do. I mean, most people will have symptoms. You don't have to, and I think I showed you that usually within 5 days, kind of that early incubation period, and there might be 2 or 3 days where you don't have any symptoms. And I know we're probably going to get a question about what about asymptomatic carriers?
Well, go ahead. You open the can of worms.
That's possible too. And I will tell you that the asymptomatic stuff right now, it's all over the place. It happens. No doubt about it. There's asymptomatic carriers. Whether it's rampant or whether it's not, I don't know, because I hear different reports.
And you're looking, when you say you hear different reports, you're reading studies and data.
Yes.
You're not reading the New York Times.
Yeah, no, absolutely. Yeah, so there's,
well, we should clarify that.
Yeah, there's two big ones. There was one in an outbreak in a prison, like 3,000 prisoners, and 97% of them were asymptomatic. You're like, that's scary, right? I mean, 97% didn't have symptoms, but could spread it. But then there was another one, it was an outbreak, maybe a different population. It was in a nursing home, and there was only 6%. So I don't know what to make of that. We don't know why, for example, God forbid, if you and I both got COVID, why one of us might get sick with pneumonia and need oxygen and not die, but get pretty sick, and the other one might be able to continue to run and exercise while they had COVID. Why? It's probably going to come down to something genetic that might be different between you and I. And just the way my body reacted to it is different than the way your body, and that's probably what's going to happen.
I don't think it's to kind of bring back the relative risks. It's pretty obvious that we can gauge pretty accurately our level of risk and those around us, unless we're in big groups of strangers.
Right. Yes.
So that's like something that I was just thinking about. It's like, I mean, in your family, I mean, the real unknown is when you step into situations where it's random people.
Right.
And that's where maybe take a few precautions.
That's right. And that's what you got to be cognizant of. And I'm in this situation. My father-in-law, wonderful man, is older and he has some pretty significant lung disease. And I worry a lot. I mean, I'm the biggest risk in my family. I'm in this stuff all the time. And even though, God forbid, anybody in my family gets it, my kids Again, statistically, I'm not worried about the death part. I don't want them to get sick. I don't want my wife to get sick. But what if they took it to their grandfather? So again, we're cognizant of that. My wife's always asking me, should I go visit him or not? You know, I had a cold a couple of weeks ago. I got tested, by the way. I'm negative 3-4 times. I got tested. But, you know, my wife, should I go visit him? Should I not? And we had those discussions. And I admit, it is a hard decision. Even for me, it was a hard decision. Because the heartstrings in me said, yeah, I want you to go visit him. But then I was like, well, what if I am sick and you're asymptomatic? What should we do? And we talked it out and made a logical decision. And so far, it seems like we made the right decision.
Which was?
She went to visit him. She never developed symptoms, and I was COVID negative. So there you go. But even being COVID negative, I totally admit, guys, this stuff messes with your mind. I was COVID negative. I was convinced I had it. Still COVID negative. Got tested twice. My wife, God love her, she's the most wonderful woman in the world. I would go to her, I think I got it. She goes, you ain't got no COVID. You just got tested negative. I said, I think I got it. So it does play with your mind a little bit. And I totally get that, and I understand the fear. But just think about it. Try to calm down. Try to think from less emotion and use more reason and facts. And I know facts, like you mentioned, can sometimes be a little bit liquid, we'll say.
Yeah. But, I mean, I think what you're kind of presenting is a moderate path that of just knowing the risks, knowing a little bit, and trying to tune out a lot of the media reports, because what the media reports do is they play on, I mean, I've often joked around about this with media, even perspectives that I somewhat agree with, is they get you angry, they get you afraid, this is going to be a little crude, but they get you sexually attracted, and then they try to sell you something. Mm-hmm. And like all of those emotions are happening with like I'm mad and I'm attracted to this person because they're really good looking, because they always choose good looking people for those roles. And like, you know, and then they show the commercials and you're like this whole cocktail of emotions. So I mean, maybe consider consuming.
Now I want to buy a chia pet.
Exactly. And now they're going to try to sell you something. That's why I joke around with Tim. I said his profession is ruining America. Marketing. Okay. Let's see if there's any other questions. This is a good presentation. I think that's it.
Well, can I ask a question?
Yeah, shoot, Tim.
Because a few people brought it up about asthma, which is pretty
Yes, yeah, absolutely, yeah. So if you have asthma, I would definitely put you in the category, again, note, doesn't mean that you will die, but I think you definitely got to be careful, and you need to be more cognizant and think about your surroundings. Number one, of everybody, listen to me. Follow what your doctors and your health care professionals say in your local area. This is driven, no matter what anyone says, by local occurrences. How bad is COVID in your area? Okay? Right now in Pitt County at this moment, thank God so far, we've got cases, but it's not overwhelming cases, okay? But we are bringing a lot of people in from all over the place right now, you know, that's coming to ECU. But always listen to what your local docs, your local information tells you about the local situation, number one. Number two, make sure you follow your doctor's advice. If you have a comorbidity, if you have asthma, make sure you take your medications. Please take your medications. Be aware of your surroundings. If you have any kind of underlying condition, do that. So again, are you going to be a little bit more risk to have a problem with COVID if you have asthma? Yes, you are. Do I think it's going to really increase your risk for dying? No, but you are going to be a higher risk though, and I want you to understand that. Just like you would be a higher risk, God forbid, if you got the flu and the vaccine wasn't totally working, or if you got a really bad cold that year and you had asthma. Okay, so just be smart, be cognizant, wash your hands, wear your mask, think about your surroundings, listen to your local docs, take your medicine. You're gonna be good, live your life.
Okay. So I think we're good to go. Well, thank you so much for your time.
Thank you.
Yeah, so this was a good presentation. We might have to do this again because I think there's a lot of interest. I'll show you the numbers afterwards. We'll see. No, I really appreciate it because,
sure.
Well, I mean, I've been grateful about between local leaders and we've talked about some of this, local leaders, local doctors, is just instead of, what I would encourage everybody is, try to ignore the national media. Like I even preached on this once. I said, the New York Times and the Washington Post and Fox News and whatever, unless something major happens in Greenville, they don't care about Greenville. They're thinking about New York and California, and they're thinking about big markets or whatever. They're not going to report on our local situation. And really the beauty of social media these days is you can find out this local information. You can get a sense of what's going on here locally. Because right now, what are the numbers for Pitt County right now?
I haven't looked today. I looked this weekend, and I want to say there had been 11 deaths, and the number of positive cases, I don't think it was over 1,000 yet. I could be wrong about that.
So 11 deaths. I mean, that would be in a typical 4-month period. Would there be as many car accidents?
I mean, in our ICU, unfortunately, that would, yes. That is, we have a lot of deaths from other reasons. And that reminds me, the one last thing I want to say, and this is really more for folks who have medical conditions and older folks, if you're listening, go to your doctor. Get your screening test. Don't be scared to go to your doctor. Please, I am more concerned, and this is recorded, I'll say it once, I've said it twice, I'll say it 3 times. I am more concerned at the very end of all this that more people are going to die indirectly from COVID than they are from COVID. Get your cancer screenings. Go get your colonoscopy. Go to your doctor about your asthma. Go to your doctor about your heart disease. Docs, and I can tell you in this town for sure, they have taken precautions. It's safe to go to your doctor. Please go to your doctor.
Absolutely. Tim, make sure you get that colonoscopy. Wait, Tim's not at the age. Sorry, when I heard colonoscopy, I was like, I got to make some kind of joke about this. No, I really appreciate it. Well, let's close with a prayer.
Sure.
In the Father, Son, and the Holy Spirit, amen. Oh, Heavenly Father, we just ask that you continue to pour your wisdom into our hearts, that as we move through the next 6 months and a year, that we may be guided by reason over our base instincts and our emotions, and just learning to recognize your divine reason and let it inform us. Help us to build a safe culture around us, but also to recognize our mission in the midst of all of this, to love and to serve and to be instruments of mercy. We ask all this through Christ our Lord. Father, Son, Thanks, Doctor.
Great, thank you. Thank you guys.